After doing all the research for this is really mind-blowing. But so it's fun stuff. These are our goals. We'll get through all these things. But first let me say, I may be your doctor for some of you, but I'm not your cholesterol doctor. I'm not your primary care doctor. I'm not your cardiologist. I'm not going to tell you to stop taking drugs. However, I might give you some information that you can use to talk to your doctor about your drugs and why you're taking them. So this is informational only. All right, so why do I care about this? Well, number one, because I live with Ashley. But number two, growing up, I grew up in a family that struggled with obesity. This is a picture of my dad, myself, and my oldest son. So my family is, in general, very heavy. They all have high cholesterol. My dad had a heart attack in his early 50s. So this is something that's very important to me. He's been on a statin for over 30 years. Continues to struggle with obesity, struggles with heart disease. So I have chosen to eat in a different way. And I'm confident with what I've learned about how I'm eating and why I'm doing it, that it's the right thing for me to do. But when it comes for me to teach my kids about how to eat, I'm really concerned about, am I telling them the right thing? Am I teaching them the right thing? And that's why I am so interested in what this is doing for our population and how and why. From a professional standpoint, like I said, I'm an orthopedic surgeon. I'm not a cardiologist or a primary care doctor, but I see so many people that are affected by this in so many ways that it's become a passion of mine. And while I am not trained as a lipidologist or a cardiologist, what I am trained in is how to look at literature, to look at the evidence, dissect information out of it, and then deliver that to people. I've written multiple peer-reviewed papers. I understand how to get this information across, and it's nice to be able to leverage that to be able to deliver this information to you guys. So the background, how did we get to where we are now? Well, in the early 1900s, there was a perceived increased rate of heart attack. There were no medications to treat it, no nutritional guidelines, nobody knew what was going on or where this was coming from. So the federal government reacted by creating several bodies, two of which the American Heart Association and the NHLBI, the National Heart, Lung, Blood Institute, among others. Their goal was to do research and figure out what is going on and what do we do about it. They started with a hypothesis that fat causes obesity and cholesterol causes heart attacks, because it's intuitive. It seems like that would be true. What's happened since then, and these studies started in the 1930s and 40s and continue on through today. So multiple hundreds of millions of dollars, hundreds of thousands, if not millions of subjects studied. And these studies continue to fail to link reduced fat intake, dietary fat intake, to controlling heart disease effectively whatsoever. This is a systematic review of all the studies up until the date of this was published, demonstrating no change in overall mortality with a modification or reduction of fat. So they continue to fail to prove their point over and over and over again. And if you've been doing that for 80 years, it might be time for a new hypothesis. So cholesterol and fat metabolism. Ashley did a great job talking about what happens when you eat carbohydrate. I'm going to go into that in a little more detail. But ultimately, over the last 80 years, we've been told that fat is bad. So we've created a fat phobia. When you stop eating fat, which it's clear that the United States and the world, as following our lead, has done, if you stop eating dietary fat, you increase carbohydrate consumption. You have to, unless you eat a ton of protein, which is difficult to do. Fat metabolism, though, is not as simple as that picture of pouring grease down the drain and watching it, gel over in the drain. That's not how our arteries work. It's much more complicated than that. I won't go into the details because I'll bore you, but basically the fat gets broken down into little molecules so that they can travel around the bloodstream, and the liver is ultimately responsible for what is in the bloodstream, and how frequently and why. So what is cholesterol? Well, number one is highly misunderstood. There's so much information in the media and in our society about what it is, and it's difficult to talk about it because the terms are confusing, and we'll go through all of them, or at least most of them. The recommendations are misleading, and even if you're a cardiologist or a primary care doctor, you have to really be careful because they keep changing over time. There's updates, there's new studies, and it's difficult. But ultimately, cholesterol is a critical biologic structure. It is absolutely important to our body. It is the lining of all cells in our body. It is the membrane that allows things in and out. It makes hormones. It makes vitamin D. It is responsible for insulating your nerve cells and getting information all the way to your feet and back. It also plays a role in the immune system. So where does it come from? Well, it can come from our diet if you choose to eat it. but your body can also make it too. If you eat zero cholesterol, your body can produce enough cholesterol so that you'll be able to continue to live, because without it, we would absolutely die. Insulin is related to cholesterol production. It's related to what types of cholesterol particles are produced as well, and that's absolutely important if you are carbohydrate intolerant, even to the smallest degree. So the basic lipid components that we've all heard and are talked about: total cholesterol, LDL, HDL, triglycerides, and VLDL, not as much, but we should. This is what a basic cholesterol panel looks like. This is my panel from this year. We can dissect it and criticize it. But ultimately, I want to point out that the LDL cholesterol is calculated, not measured, and I'll go in detail what that means because it's very important. And VLDL is there, and nobody's talking about it, or few people are talking about it, and we should talk about it. And the other two things in here that are really important, triglycerides and HDL. So what does it mean that the LDL is measured? Well, calculated. To actually measure LDL particles and cholesterol, it takes more time, it's more expensive, so it's not frequently done. This equation was made in 1972 called the Frito equation, which is your total cholesterol minus HDL plus triglycerides over 5. And that's fine and accurate if your HDL and triglycerides are at a certain ratio. If they're not, then the measurement is off. And so if you restrict carbohydrates, especially initially, your triglycerides will bottom out, which is a good thing. Your HDL will rise, but slower. So initially, you could have an estimated LDL that's much higher than it really is. And if I'm a primary care doctor and I'm going by the guidelines, that could scare me, and we could talk about taking a statin drug, even if it's not true. So HDL versus LDL. This is the good versus evil that we've been hearing about in the media for the last 50 years or so. But most people don't know the cholesterol in HDL and the cholesterol in LDL are the same thing. Same particle. Same thing, but on a different bus. So the HDL and LDL particles are going either from the liver or to the liver, depending on what they are. And you need to think of these particles like a bus or a car. And the cholesterol is what's on the bus, among other things. So we're talking about the vehicles and what direction they're going, not necessarily what's in them. And that's why this gets really confusing. So these particles are also called lipoproteins. And when you look at the cholesterol panels, especially the more advanced one, you see the C and the P. The C stands for cholesterol, the P stands for particle. In the particle, you have both fat and protein. The protein is protected by the fat. The fat is made up of triglycerides, cholesterol, fat-soluble vitamins, all good things. But these particles come in different sizes. And that's very important when it comes to figuring out which ones are dangerous and which ones are not. So total cholesterol. A lot of people like to talk about total cholesterol. Oh, my total cholesterol is 250. Well, what does it tell you? Not much, unless it's 500. Because it's like saying, how was the game last night? Great, the total score is 57. So who won? Was it tight? Was it a double overtime? You know, what was the game like? It doesn't tell you anything at all. So that's why there are no current recommendations based off of total cholesterol. There are no therapeutic goals, whether it be dietary or pharmaceutical, based on total cholesterol, and that's the last time I'll mention it. HDL, it's the good guy, and it really is the good guy. So HDL returns cholesterol to the liver. It is the bus that picks it up and takes it back to the liver to figure out what we're going to do with it next. It scavenges it from everywhere. But it does a bunch of other stuff too. It increases the bioavailability of nitric oxide, which has implications with vascular function and blood pressure. It's an antioxidant, an anti-inflammatory, an antithrombotic, an anti-apoptotic. Those are all good things. All right, so HDL is really good. The evidence that supports that is very strong. So there's an inverse correlation with coronary heart disease, meaning that the higher your HDL is, the lower your likelihood of getting or having a cardiac event. It's an independent risk factor in this ASCVD, which is atherosclerotic coronary vascular disease, meaning vessels and heart disease. It is an independent risk factor, which means it's really important in determining if this is going to be a problem for you in the future. It's so important that a normal HDL level is 30% more protective than a low LDL level, which is what pretty much every pharmaceutical goal is trying to do, is to decrease your LDL level. And we'll talk about why. The therapeutic goals, therefore, are to have HDL as high as possible. Triglycerides, fat. Fancy way of carrying around fat. So these little three things coming off of here are fatty acids. And we're talking about monounsaturated, polysaturated. That's different types of fatty acids. They are all packaged in a triglyceride, for the most part, and carried around the body. This is directly related to carbohydrate consumption, as Ashley mentioned, and that's called de novo lipogenesis. Your body's consuming too many carbohydrates, it can't store them anywhere else, it goes to the liver, it makes fat, comes out as triglycerides, and it comes out in VLDL, which are very dangerous. The evidence to support that also very strong. So elevated levels are associated with an increased risk of cardiac death in those that already have ASCVD. It's an independent risk factor for developing heart disease in young men less than 55. Elevated levels are correlated with developing diabetes, and that's that triglyceride effect, consuming too many carbohydrates. The ratio of triglyceride to HDL is becoming more and more important, and literature is looking at that very, very closely as a goal. So the therapeutic goal for triglycerides, as low as possible. So when you look at HDL and triglycerides together, they've become known as the atherogenic lipid profile, meaning that when your HDL is low and your triglycerides are high, that's dangerous because they're associated with these VLDLs, and VLDLs we'll talk about, but they break down into something that's easily oxidative and damaging to your vessels. Therefore, this low HDL, high triglyceride is independently predictive of developing diabetes and will predict heart disease and coronary vascular disease mortality. All bad stuff. This was published in the American Journal of Cardiology in 2005, that's 13 years ago, talking about patterns of lipids. And we'll talk more about that, but pattern A is better, and if this ratio is lower, you're more likely to have pattern A, and as this ratio goes up, you're more likely to be insulin resistant. So it's a nice way to look at two very important things. So again, pattern A, big, fluffy, happy. The reason why they're happy is because they have more cholesterol, more triglyceride protecting the protein. It keeps the protein from being oxidized, and oxidized protein is inflammatory and can damage your vessels. Pattern B are small, scary, not enough fat, protein's exposed. Your immune system can attack it and cause damage. So VLDL, these are little dangerous guys. So they're on the spectrum of LDL, which we'll talk more about, but this is how triglycerides that are made in your liver get around the body. Carry some cholesterol as well, but for the most part, these are triggered by insulin. And as insulin levels go up, especially if you're carbohydrate intolerant and insulin resistant, you're going to make more of these and they're going to get bigger. This is the only time when big is bad. VLDL big is bad because it's full of triglycerides. Also, when your body's busy making VLDL, it can't make HDL. And we've already talked about the fact that that's bad. So VLDL, as it goes around the body, it drops off all the triglycerides to the cells, which are hungry. It becomes an ILDL, a cholesterol-poor LDL, and subsequently a small LDL particle. Now you say, gosh, we're getting to this particle stuff, it's getting confusing, but small LDL is bad. All right? So is there evidence to support that? Absolutely. So as the number of these particles go up, your risk of coronary vascular disease goes up. It's associated with that decreased HDL and HDL particle size and concentration. It's associated with more triglycerides, obviously. It's associated with developing diabetes. So the therapeutic goal is few of these and as small as possible. All right, so here's LDL. This is the bad guy. This is the guy that we're told in the media that's going to kill us. We need to get it down as low as possible. And there's some evidence to support that. But what it is it's cholesterol being carried from the liver to the cells. So it is the major pharmaceutical therapeutic target. So statin drugs, which we've all heard about, statin drugs lower LDL. But LDL has a broad subtype pattern, meaning that there's a lot of different types of LDL. So when you look at what LDL actually does to the body, it's a little bit difficult to actually figure that out because there's so many different types. So as I mentioned, statins reduce LDL cholesterol. Statins reduce coronary heart disease events. Absolutely true, no question. However, coronary heart disease events also occur with normal LDL. So it's not just the LDL. Fat-restricted diets can lower LDL, but not always. But fat-restricted diets lowering LDL do not produce a change in coronary heart disease events, as I mentioned in the beginning. A couple of studies to demonstrate that. The Women's Health Initiative was a massive trial. 49,000 participants, 20,000 of them on a fat-restricted diet. They did demonstrate that you could lower LDL through nutrition. However, after following these women for decades, there was no difference in heart attack, stroke, obesity, or overall mortality. Oops. The Lion Diet Heart Study. fat-restricted diet versus carbohydrate-restricted diet. So this one I really like. I want to know which one did better. Well, there was no difference in LDL between the two groups, and they actually stopped the study after 27 months because the mortality rate, the likelihood of dying, was so much higher in the fat-restricted group that they canceled the study and said everybody should eat the other way. Well, that was over almost 20 years ago. So what's the role of LDL cholesterol? Well, like I said, there are a few associations with LDL cholesterol, and the literature doesn't really support doing anything with it because there are so many different parts. There's ILDL, VLDL, LDL particle size. What are we actually treating? Now, statins lower LDL. Statins prevent heart attacks. But is LDL responsible for that? So the therapeutic goal, it's really based off of statin use. If you're on a statin drug, there's going to be a goal associated with that. But from a nutrition standpoint, it's the particle size that we're interested in. So how do we figure out what our particles are? What is this particle thing you're talking about? Well, to learn that, you have to have an advanced lipid profile. There's a few of these on the market. This is actually mine and my dad's. So these are particles and cholesterol. If it ends with P, that's the particle number. If it says size, that's the size. So it gives us a lot of information, and at the bottom you can see that thing called LPIR score. That's a measure of insulin resistance. So LDL particles. Now this is where you can tell what LDL is actually doing. So LDL particle number or concentration is an independent predictor of heart disease. If you have a lot of small LDL particles, it's associated with an increased risk of heart disease and developing diabetes. Why? Because these things are hard to clear from the arterial system. So the little guys have a hard time picking them up. The liver can't necessarily get to them, and they're in there for longer, potentially days to weeks longer, and your immune system has a chance to find the protein, attack the protein, oxidize it, and then it becomes worse, and it can actually damage the arterial walls. So LDL particles, we want less of them. What about LDL size? Well, as I mentioned, small LDL is bad. In fact, the smallest of the LDL subfractions are the best predictor of worsening stenosis. If you have heart disease, they're going to get smaller and smaller, which is not good. And again, it's more oxidative, it's more inflammatory, causes atherosclerosis. So you want them basically as big as possible. You have to have LDLs. You have to get cholesterol from the liver to the cells, but you want them to be big, and you don't want very many small ones. So oxidized LDL is where you can really tell what's going on. It is most closely associated with atherosclerosis. It is predictive of heart disease in young patients, and it's shown to be absolutely cytotoxic to the cells. It is attacking the cells and the lining of the arteries. Unfortunately, it's not easy to test yet. It's coming. It's out there. You can do it if you seek it out on your own, but it's not currently part of mainstream testing. So HDL particles. All right, we already said HDL cholesterol is great. HDL particles are great too because they carry HDL cholesterols. But if those particles get smaller, then it does have an association with heart disease, diabetes, high triglycerides, and low HDL cholesterol. So you want your HDL particles to be as big as possible. Are we confused yet? Okay. The LPIR score, like I said, it's a measure of insulin resistance. It doesn't really matter how this is calculated, but it's a weighted measure of all these particles and cholesterol levels and sizes. And some very nice studies, like the Jupiter study, this is a massive study from over 1,300 sites, 26 countries, 18,000 people that are on statin drugs, looking at exactly what it's doing to the LDL, exactly what it's doing for how many people develop diabetes and what were their particles. So you can get a lot of information out of studies like this. And they actually used this study to verify the LPIR and to validate that. So that Jupiter data demonstrated that statins will lower LDL. Absolutely. It can lower it by 50%, which is pretty huge. It'll lower your VLDL 20%, pretty good. Triglycerides 15%, okay. But it also lowers your LDL particle size, which is a little bit concerning, and it raises nothing. Carbohydrate restriction. It does variable things to your LDL, and this is where we get a lot of questions, right? So I started eating this way, my LDL went up, or my LDL went down. My LDL went up, what does it mean? It can do a bunch of different things, and we'll talk about that. But carbohydrate restriction will absolutely raise your HDL particle size, your LDL particle size, your HDL particle concentration, and your HDL cholesterol. All good things, right? It'll lower triglyceride levels, good thing. Lower insulin levels, good thing. But again, if I take carbohydrates out, I have to eat fat. I've heard saturated fat will kill me. True, kind of. But you got to look at the word in front of that. Serum saturated fat versus dietary saturated fat. So it's true, serum saturated fat is associated with heart attacks. It will predict a heart attack, in fact. But serum saturated fat is associated with carbohydrate consumption, creating VLDLs. When you make a triglyceride molecule from carbohydrate, the most common thing for your liver to make is palmitic acid. That's 16 to 0. That means it's fully saturated. So when your body consumes more carbohydrate than it can tolerate, it creates serum saturated fat. Got it? Okay. Dietary saturated fat. Well, Ashley already mentioned this. Here's 4 studies demonstrating that increased consumption of dietary saturated fat equaled lower serum levels of saturated fat. And if that wasn't enough, this is her slide. I love this because this is almost 1 million people followed for up to 25 years. No increase in heart disease, stroke. It's unbelievable. Evidence doesn't really get better than that. Okay? So where are we now? Well, statin therapy is almost $7 billion in annual sales. So it's a tremendous drug, and it's helping a lot of people. It might be overprescribed, but it does reduce coronary events. You can't hide from that. However, the mechanism isn't clear. That same Jupiter study also measured C-reactive protein, which is a measure of inflammation. If the inflammation goes down after you take your statin drug and you don't have a heart attack, is it because the LDL went down or because your inflammation went down? And it's hard to answer that question. From a nutrition recommendation standpoint, the federal government and most governing bodies continue to persist to try to prove that low-fat diets are saving our lives, and they continue to fail. HDL-raising pharmaceutical treatments do not exist. Triglyceride-lowering pharmaceutical treatments do not exist. This was a great study. 13,000 men followed these guys for a long time with a dietary cholesterol-lowering trial. No significant difference in heart disease deaths, and overall mortality was no different whatsoever. Just continue to try to prove it over and over again. I like this study. So this is carbohydrates versus fat restriction, looking at 32 different randomized control trials. And randomized control trials, level 1 evidence, best evidence you can get. What they showed is that low-fat diets will decrease your overall cholesterol, will decrease your LDL cholesterol, but to what gain? High-fat diets will increase your HDL cholesterol, decrease your triglycerides. Both good things. If you starve yourself on a hypocaloric diet, your lipids will not change whatsoever. HDL was always associated with more fat intake. Triglyceride increases associated with triglyceride intake. So let's talk about recommendations real quick and we'll wrap this up. So in 2003, the federal government said this is what adults should be treated with if they have high cholesterol. They used treat to target scores for LDL, meaning that if your LDL was high, you were put on a statin drug, and they wanted to get it to a certain level, 100, 70, or lower. That has gone away. And the reason why I bring this up is because we still hear people come in and say, my doctor told my LDL has to be under 70. That has been abandoned. The Framingham risk score, which is what they used to get their risk of coronary vascular disease over the next 10 years, has also been abandoned. It's been replaced, not abandoned. What I really like about this, in 2004, the American Heart Association, National Heart Lung Blood Institute, American College of Cardiology, all came out and updated the ATP3 together and said that we should consider therapeutic lifestyle changes before instituting statin drugs. Those lifestyle risk factors are obesity, low HDL, high triglycerides, and metabolic syndrome. I know one thing that can treat all 4 of those. What is it?
Fat.
Fat, carbohydrate restriction, yeah, all those things. So, absolutely. So in 2013, the new guidelines came out, nicknamed ATP4. They have a much longer name up there. So they changed the risk stratification to this thing called the pooled cohort equation, and it gives you a 10-year % chance that you're going to have a heart disease event. There are a lot of variables that are built into that. LDL cholesterol is not one of them. Okay? There is no more treat to target. We're not trying to get your LDL to 100 or 70 or 10 or whatever, but they do monitor the effectiveness of the drug. The threshold of having a 10-year event has been lowered to 7.5% from what it used to be. But they also talk about some additional factors and things that they think are important. CRP, inflammation. And then there's this abnormal coronary artery calcium score. So this is a way to actually look at your vessels on a study and figure out, do you have atherosclerosis? Is it getting worse? And that's something that we're probably going to start hearing more about. This is what this looks like. You can find it online. That's the link. You can plug in your own numbers and figure out what your % chance is of having an event in the next 10 years. It's estimated. But this is information that you can take to your doctor and say, but my risk is really low and my cholesterol levels are this. You know, let's talk about why we're doing this drug, and just have an open conversation about it. There are other government-funded agencies that have recommendations as well, and they are only increasing that ASCVD risk from 7.5 to 10% or 7.5 to 15%. And the reason why they do that is because they say they can't justify the cost and the side effects of statin drugs. So carbohydrate restriction, again, what does it do? Increases HDL cholesterol, HDL particle size, HDL concentration, and LDL particle size. All great things. It decreases triglycerides, small LDL particles, VLDL particle concentration, and VLDL particle size. All great changes in your lipid profile. So takeaway points. Total cholesterol no longer has a role in risk assessment. If somebody's talking to you about what your total cholesterol number is, please ask them to be more specific. Fat-restricted diets continue to fail in large, hundreds of million-dollar government and industry-funded trials to demonstrate any improvement in coronary artery disease and coronary vascular disease development or events. LDL cholesterol continues to be the pharmaceutical goal because that's what we can affect a difference in. But the question is, what are we actually doing with those drugs, not if they're not important. An advanced lipid profile might give you more information about that LDL cholesterol, and if your LDL does go up on a carbohydrate-restricted diet, like mine did, learn more about it and see if you're actually at risk. HDL cholesterol, particle, concentration and size, and triglycerides are likely more relevant and more important in predicting heart disease than LDL levels. Those can only be affected by nutrition therapy. There are currently no pharmaceutical drugs that can affect these things significantly. Unfortunately, large randomized control trials to prove this are lacking. The funding is lacking because the major funding source for changes in the lipid panel are driven by pharmaceutical companies. So consider statin therapy when the benefits outweigh the risk, and again, that's a conversation between you and your doctor that's prescribing them. So, what do you do now? Discuss your profile with your doctor. It's absolutely important to have that conversation, but you have to come in with the tools to have the conversation. Okay? If your LDL is elevated, you probably need to know more about it. And ultimately, we all should be living within our carbohydrate tolerance. I eat a very low carbohydrate load. I just don't tolerate it very well. My family doesn't tolerate it very well. I see people in the audience that I know tolerate it really well. But it's all different, right? And you have to figure out what's right for you. But if you do that, your triglycerides will go down, your HDL will go up, your insulin levels will go down. And beware of this concept of transient hypercholesterolemia. If you're doing a program where you're burning fat and you become this awesome fat-burning machine, your LDL might do this, okay? Don't test it in here unless you're really high risk of heart disease. And talk to your doctor about it, but have an open conversation. And expect that when you get to your goal, it's going to come back down, okay? So, additional test, CRP, easy, cheap, simple. It'll tell you what your inflammation level is. Coronary artery calcium score, probably not as easy to get. I don't know where we can get it, but I bet our hospital does it. NMR lipoprotein test, relatively easy to get, not that expensive if your insurance doesn't cover it. And oxidized LDL will be getting easier, hopefully, in the next few years. And that's it.